And that takes us to, on page 15, the lymphocytes. They account for 25% of all your white blood cells. They are formed in the lymph nodes, tonsils, appendix, spleen, and other lymphatic organs. Now, there are two types of lymphocytes, the B lymphocytes, and down here the T lymphocytes, also called B cells and T cells. Now, I wrote that they originate in the bone marrow. And you say, wait a second, I'm really confused. You just told us they're not made in the bone marrow. When I say they originate, I mean in the embryo. They originate in the embryo, in the bone marrow, in the embryo. So they are formed, they originated in the bone marrow. That's why they're called B cells or B lymphocytes. And then they leave the bone marrow. They migrate and leave the bone marrow, and they populate your lymphatic organs. So they travel through your bloodstream, from the bone marrow, travel through your bloodstream to your lymph nodes, your tonsils, your appendix, your spleen, your lymphatic nodules in your intestine. And as an adult, there are no B lymphocytes in your bone marrow, none. They all left them during, as an embryo, as a fetus, and also during childhood. All right, but as an adult, they all have left the bone marrow. That's simply where they embryologically originated from. And that's how they got the name B cells, or B lymphocytes.
Do they then still produce more?
Yes, they continue to multiply in your lymph nodes and spleen and tonsils. So you're always making more. But now they're made in your lymphatic organs. Now, what do the B lymphocytes do? They produce immunoglobulins. Immunoglobulins are also known as antibodies. So the way that I try to remember B lymphocytes is the B lymphocytes produce the antibodies. They produce the antibodies, okay, which are more properly called immunoglobulins. But that's how you remember them. They produce the antibodies. Now, what do immunoglobulins do? Now, if you ever had me for anatomy, and even in this class earlier in the semester, when I was explaining what antibodies do, I said they inactivate foreign agents. But that wasn't very precise. Now I'm going to be a little bit more precise, specific as to what they do. And immunoglobulins, antibodies, cause precipitation and agglutination. They cause opsonization, and they cause lysis. To show you what we mean, look on the next page. Look on the next page at the bottom. At the bottom of page 16. Now, when you take microbiology, you will learn that antibodies are proteins that actually are shaped like a letter Y. They actually have that shape like a letter Y. I'm not going to get into the details of that. That's for micro. Now, what do antibodies do? They're released from the B lymphocytes, and they can attach. Well, let's start over here. They can attach to cells, foreign cells. And when they attach to foreign cells, they cause these foreign cells to clump. That's called agglutination. Agglutination is clumping of foreign cells. Now, that means antibodies could attach to bacterial cells and cause them to clump or stick together. Antibodies could attach to the foreign red blood cells. If you were given the wrong blood type, where your red blood cells are blood type A, and you were given the wrong type of red blood cells, blood type B, the antibodies would attach to those foreign red blood cells and cause them to clump, and that's called agglutination. Hannah, does that make sense? That was your question earlier. All right, so now you might say, what does that accomplish? If antibodies cause bacterial cells to clump together, what does that do? It prevents them from going anywhere else in your body. They're all clumped and stuck together. And that makes them really easy, because they're all clumped together, for a macrophage to just eat them all up. They're not going anywhere now. Now, the antibodies over here can also attach and cause clumping of chemicals or viral particles. When they attach and cause clumping of viral particles, viruses, or toxins chemicals, that's called precipitation. It's really very similar to agglutination. It's just that agglutination refers to antibodies attaching and causing clumping of cells, and precipitation is when the antibodies attach and cause clumping of something that's not a cell. A viral particle, viruses are not cells, or a toxin, a toxic chemical, or something like that. Now, what else do antibodies do? Antibodies can attach to bacterial cells and cause the bacterial cell to rupture. That's called lysis or cytolysis. Lysis. And another thing that antibodies do is when they attach to bacteria, they attract phagocytes to swallow them up. They attract phagocytic cells such as neutrophils or monocytes to swallow them up. That's called opsonization. I always think of this as a little bit like, think of it when an antibody attaches to a bacteria, think of it as like a flare. You'd say, what? You know when you have a traffic accident, you put flares out? Does anybody know what I'm talking about? Yeah. All right, so you put a flare. What does that do? It attracts your attention. So this antibody attached to a bacteria attracts the attention of a white blood cell to now swallow up that bacteria. That's called opsonization. So these are just pictures of what I wrote on the previous page. So what I wrote on the previous page, what do antibodies do? They cause clumping of foreign agents, viral particles, bacterial toxins, that's called precipitation, clumping of bacteria, that's called agglutination. They cause opsonization, where they mark a foreign agent for being swallowed. They play a role in the inflammatory response. Don't worry about that, I'm not going to get into it. And they cause lysis, where they lead to lysis or rupturing of foreign cells. Okay, we've been talking about the B lymphocytes, the B cells that produce the antibodies. Now, there was another type of lymphocyte called the T lymphocytes, or T cells. They get that name because they originate in the thymus. And even though I wrote thymus gland, we're going to cross out gland because it's not really a gland. Now, when I say that the T lymphocytes originate in the thymus, I mean in the embryo. Now, what is the thymus? You should have learned this in anatomy. The thymus is located in a child, in an embryo, in a fetus, and in a child, between your thyroid gland and your heart. You'd say, what? Where's your thyroid gland? Your thyroid gland is on the sides of your larynx, or your Adam's apple. So if you feel your larynx, just on the side of it is where your thyroid is. You know where your heart is. The thymus begins below the thyroid and extends all the way to just above your heart in a child. You don't have a thymus. None of you in this room have a thymus. You'd say, I'm confused. The thymus, that thymus organ degenerates. It shrivels up beginning at puberty. So beginning at the age of 12, that thymus shrivels up. But what was the thymus for? During childhood, it produced these T lymphocytes, or T cells. Where did these T lymphocytes that it produced, what happened to them? They migrated. They left the thymus, and they populated the lymphatic organs. So the T cells left the thymus and traveled through the bloodstream to the lymph nodes, to the tonsils, to the appendix, to your spleen. So what happened to the T cells is exactly what happened to the B cells. The B cells originated in the bone marrow and they left. The T cells originated in the thymus and they left. Now, today as an adult, there are no B cells in your bone marrow and you don't even have a thymus. But in your lymph nodes, you have both B and T lymphocytes. In your tonsils, you have both B and T lymphocytes. In your appendix, you have both B and T lymphocytes. So they get their name from where they embryologically originated. Now, what do the T lymphocytes do? So on page 17, in micro, you will learn that there's at least 4 different types of T lymphocytes. I'm only going to tell you about 2 types. There are the helper T cells, and there are the cytotoxic T cells. Now, we'll call them helper T cells. In a micro class, they also call them CD4 cells, and because they have that number 4, they're also known as T4 cells, if you've ever heard that term. But we'll just call them helper T cells. The cytotoxic T cells, that's what we'll call them. In micro, they also call them CD8 or killer T cells. Now, what do the helper T cells do? The helper T cells release chemicals. They release chemicals including interferon. What is interferon? I'm sure you've heard of it. It is a protein that interferes with viral replication. It interferes with the multiplication of viruses. It interferes. It's called interferon. What else do these helper T cells do? They release chemicals called cytokines. Cytokines activate B lymphocytes, and they also activate, not only do they activate the B lymphocytes, they also activate these cytotoxic T cells. So the cytokine chemicals that are released by these helper T cells activate both the B lymphocytes and they activate the cytotoxic T cells. What do the cytotoxic T cells do? The cytotoxic T cells rupture. They cause rupturing of cells, of foreign cells or infected cells. And infected cells. They cause rupturing of foreign cells and infected cells. I'm going to explain this better momentarily, just before we do. What is lymphocytopenia? Penia always means low. So a low lymphocyte count. Now, one reason why somebody might have a low lymphocyte count, just like they'd have a low white blood cell count, is chemotherapy. But another reason why specifically just the lymphocyte count might be low and not the other types of blood cells is they have HIV. HIV is a virus. It stands for human immunodeficiency virus. What does this virus do? You've all heard of it. This virus is a lytic virus that enters and destroys helper T cells. It destroys the helper T cells. Since the helper T cells play a key role in your immune response, having HIV basically destroys your immunity. That's why it causes a disease called AIDS. AIDS stands for Acquired Immune Deficiency Syndrome. Immune deficiency. Why are they deficient in their immune system? Because the virus is destroying the T lymphocytes, which play a critical role in the immune response. All right, now lymphocytosis, that's higher than normal lymphocyte count, and we've said that usually when white blood cells are elevated, that's an infection. And specifically, elevated lymphocyte count is indicative of a viral infection. Elevated neutrophil count is a bacterial infection. Notice how we read, these each are interpreted a little bit differently. Let's try to just clarify the immune response. Let's look at the next page, page 18. All right. Now, in micro, when you take micro, you will hear all about this subject in far, far greater detail. But for the purposes of this class, here's what we want to say. When the helper T cells are activated, and I'll tell you a little bit about how they're activated, but when helper T cells are activated, they release chemicals called cytokines. These cytokines activate both the B cells, which produce antibodies, And the cytokines activate the cytotoxic T-cells. Now technically, as you will learn in micro, when a B cell has been activated, they change its name and they call it a plasma cell. We've already told you what antibodies do. Antibodies cause precipitation and agglutination and opsonization and lysis. When the cytokines activate the cytotoxic T cells, the cytotoxic T cells cause rupturing of foreign cells or infected cells. What did we say the HIV virus does? It destroys the helper T cells. So if you destroy the helper T cells, then you can't activate the B cells to produce antibodies or the cytotoxic T cells to attack bacteria. All right, now, one more picture. And I'm not so much going to ask you to know this. This is really showing really the same thing. Here's a helper T cell. And this is the part of the picture. I'll come back to this very top picture in a moment. But here it shows the helper T cell. It says T helper cell is activated. What does an activated helper T cell do? It releases these chemicals called cytokines.
What page is that?
This is page 19. Here it shows this helper T cell has been activated, and it's releasing cytokines here and here. These cytokines activate the B cell. The B cells produce the antibodies. Here it's showing these cytokines released by the helper T cell activate this cytotoxic T cell. And what does this cytotoxic T cell do? It approaches this cell that is infected with a virus, and it ruptures it. It destroys it. The first picture at the top, I'm not going to test you on. But how do you activate? How do you activate a helper T cell? Since obviously that's the critical step. The way that a helper T cell is activated is it involves macrophages swallowing up a virus or a bacteria. And you'll hear about this in micro. When a macrophage swallows up a bacteria or virus, it chews it up, and pieces, you're not going to believe this if you haven't heard this before, pieces of the virus or bacteria then appear on the surface of the macrophage. And this is called an antigen epitope. I'm not going to test you on that. But what an antigen epitope is a part of the chewed up virus or bacteria that appears on the surface of this macrophage. And the helper T cell makes contact with it, and that activates it. The last thing I want to do is let's look at page 224A. 224A. We have looked at this page before. And we had told you that if we ever came back to this page, you would understand a large part of this page. Now, I think it's fair to say that if you had looked at this on the first day of this course, you would have said, I don't know what any of this is. This is showing the most common blood tests that are typically run. Page 224, it says it right up here. Okay, these are the most common blood tests that a doctor or a hospital runs. Now, there are thousands of tests they can run, but these are the most common. Now, the only information we're given here on 224A is that it's a female. It says F, female. And the way this lab form is set up, is that if the number appears above the dashed line, it's within the normal range. If the number appears below the dashed line, the number is either lower or higher than normal. All right, so let's take a look at this and see what we understand. The very first number here on the top left is the blood sugar level, the glucose level. What did we ask you to memorize is the normal glucose level in the blood? 100 milligrams per deciliter, 100 milligrams per 100 milliliters of blood, or 100 milligrams per cent. They all mean the same thing. You need to memorize that. I'm testing you on that. I want you to know it. Since you know it, the fact that this patient has 103, you know, that's pretty normal. That's pretty normal. That's a normal. You don't have to look it up. You know that that's approximately a normal blood sugar level. Now, the next number we're not really going to worry about. It says protein-bound glucose. What does that mean? We know there's protein circulating in our bloodstream, plasma proteins, and some of the sugar attaches to the proteins. That's called protein-bound glucose. Obviously, whatever it is, hers is normal. The next number, the Bunn level. Have we ever learned what Bunn is? What does it stand for? Blood urea nitrogen. We have learned this. So that's when we measure the amount of urea in the bloodstream, that's called the Bunn level, the blood urea nitrogen. Urea is an organic waste product formed from the breakdown of amino acids. Proteins are amino acids. It's formed in deamination. We learned about that in section B on cellular respiration. Okay, so yes, you have to know it. Her Bunn level is normal. What if her Bunn level, her urea level, was higher than normal? What if her urea level and other waste product levels in her blood were higher than normal? What's the most likely cause? Kidney failure. Very good. Because if your kidneys don't work, their job of the kidneys is to filter out and excrete waste products. So if the waste product levels are higher than normal in the bloodstream, you probably don't have kidneys that are working right. Now, creatinine. We have mentioned creatinine is a waste product formed in muscle tissue. Because of time constraints, we didn't learn anything more than that, but it is a waste product formed in muscle tissue, and this waste product level is normal. The ratio of her Bunn to creatinine level is not normal, but we're not going to get into it. We're not going to talk about it. Now, the next several things listed are enzymes. Enzymes. We have learned that the doctors measure these enzyme levels in the blood, and if they are higher than normal, that means there's injury, pathology, disease associated with a particular tissue or organ, because different enzymes are associated with different tissues of the body. Now, of these enzymes that are listed, the only one that we want you to know is ALT. We learned about ALT when we were doing that Lipitor exercise. That's the liver enzyme. So if it were higher than normal, it would indicate liver disease, liver damage, infection in the liver, tumor in the liver, something is wrong in the liver. Her liver enzyme level is normal. Now, the next thing that I've highlighted here, it says total bilirubin. Have we learned what bilirubin is? Bilirubin is a kind of greenish-yellow chemical formed from the breakdown of hemoglobin. We've covered that in hematology. And so her bilirubin level is normal. But if the bilirubin level is higher than normal in the blood, it causes, well, there's many reasons. The body is breaking down a lot of red blood cells or hemoglobin very quickly, and it causes yellowing of the body. That's called jaundice. Jaundice, J-A-U-N-D-I-C-E, jaundice, is yellowing of the body because of hyperbilirubinemia, high bilirubin levels in the blood. The most common reasons for jaundice and high bilirubin levels are liver problems, liver disease, liver problems. Okay, now the last thing listed on the right is the calcium level. We did not ask you to memorize what a normal calcium level is in the blood, but what we do want you to know is that calcium is very important for two major things: muscle contraction and blood clotting. And when the calcium level becomes abnormal, it especially is going to affect muscle contraction and blood clotting. And when I say muscle contraction, that includes heart muscle. Now, the second row, we didn't learn too much about phosphorus or magnesium, in this class, but we sure as hell learned a lot about sodium and potassium, the next two. We memorized the normal sodium level in the blood is approximately 150 milliequivalents per liter. You need to know that. Hers is 137. That's within the normal range. The normal potassium level that we asked you to memorize, normal potassium in the blood should be about 5. Hers is 4.1. That's within the normal range. Potassium is the major mineral or electrolyte that determines the electrical voltage of every cell in the body. That's what determines the membrane potential, the electrical voltage of every cell in the body. We have talked about hyperkalemia and hypokalemia and how changes in potassium level, extracellular potassium, cause changes in the electrical voltage of every cell in the body, and that can be fatal. We know that sodium is very important in the generation of action potentials. Sodium has to flow into excitable cells like nerve cells or muscle cells in order for them to generate an action potential. We have also told you the hormonal mechanism that regulates the sodium and potassium electrolyte levels. That's the renin-angiotensin-aldosterone reflex. That's very important. The renin-angiotensin-aldosterone hormonal mechanism reflex is what regulates the sodium and potassium mineral levels. Those are the most important minerals or electrolytes in the body. All right, well let's go to uric acid. Now, uric acid is an organic waste product formed from the breakdown of nucleotides or nucleic acids. We learned that in section B. Now, her uric acid level is higher than normal, right? It was written below that dashed line. She has hyperuricemia. Now, the fact that she has high uric acid level, in her case, knowing what we've covered so far, does she have kidney failure? No. She doesn't have kidney failure. She can't because her urea level and her creatinine levels are normal. If your kidneys don't work, then the waste products, all waste products accumulate in the blood. Well, her urea and your creatinine levels are normal, only her uric acid level is higher. What is that name of that disease where people have higher than normal uric acid levels? Gout or gouty arthritis. She's got gout. That's a metabolic disorder. But the only way she'd have kidney disease is if the waste product levels, all the waste product levels were higher than normal. She's got gout. We'll come back to that. Now, the next thing listed is her triglyceride levels. Triglycerides are fats. And hers is 254. It's written below the dashed line. It is much higher than normal. Right next to that is her cholesterol level. Her cholesterol level is 317. What did we ask you to memorize? That the cholesterol level should not be any greater than 200. It should be less than 200. Hers is greater than 200. Now, we know that fats and cholesterol lead to atherosclerosis. Now, what else do we notice? It gives her HDL and her LDL level. These are lipoproteins that transport cholesterol. You remember the HDL is the healthy one. The LDL is the lethal one. Now, while her HDL is within the normal range, her LDL is much higher than normal. She's got too much of this lipoprotein that transports cholesterol from her liver to the walls of her arteries. This is not good. She's got high triglyceride levels, high cholesterol levels, and high LDL levels. Let's look on the back side of this form for a moment. On the back side of the form, you will notice towards the bottom of this back side of the form, it talks about cholesterol, triglyceride, HDL, LDL, but let's focus in on this chart right here. So, what was her cholesterol level? Her cholesterol level was 317. What was her LDL level? What was her LDL level? 233. Is that right?
Yeah.
So can you see that with a cholesterol level greater than 240, 317, and an LDL level greater than 160, hers was 233, she is at high risk of coronary artery disease. What's coronary artery disease, or coronary, here they call it coronary heart disease, it's the same as coronary artery disease. That means that her coronary arteries are at high risk of being all clogged up. Why do we care? Clogging up of the coronary arteries increases the likelihood of a coronary thrombosis, a blood clot, and that blood clot in a coronary artery leads to myocardial infarction or a heart attack. She is at high risk of having a heart attack. We'll come back to this before we're done. Now, let's go back to the front side. Where were we? All right, the total protein level. Her total protein is 7.6. We know, we've asked you to memorize, the normal protein level in the blood is 7%. 7 grams per 100 milliliters, 7 grams per deciliter. What's the major protein in blood? Albumin. More than half the protein in the blood is albumin. She has a normal albumin level. Since proteins in blood are what create a colloid osmotic pressure that draws water back into the bloodstream at the level of the capillaries, and what's the major protein? Albumin. So the main function of albumin is to create a COP, a colloid osmotic pressure, that osmotically draws water back into the bloodstream. Remember, blood pressure causes water to squirt out of the capillary. The proteins in the blood, principally albumin, osmotically draw water back into the bloodstream. But hers are all normal. If they weren't, that would be, she would be at a higher, greater risk of edema and stuff like that. Okay, now, the next row. After albumin, there are globulins. We have learned that there are alpha globulins and beta globulins that transport fats and minerals in the bloodstream. Hers are all normal. Her iron level is normal. If it was lower than normal, she might be anemic. Now, there are some things here that are listed that are not in the normal range, but we're not going to talk about them. But we are going to mention is WBC, her white blood cell count. Notice how the way they list the white blood cell count is in exponential notation form. That's why I told it to you that way. We asked you to memorize that a normal white blood cell count is approximately 7 times 10 to the third. Hers is 6.8 times 10 to the third. That's within a normal range. We know what it means if she had either higher or lower than normal. If it's lower than normal, maybe she's undergoing chemotherapy. If it's higher than normal, maybe she has an infection. Okay, then the red blood cell count. We asked you to memorize that a normal red blood cell count is 5 times 10 to the 6th, 5 million. Hers is 4.73. That's within the normal range. Notice that women, females, have a lower red blood cell count than males. But hers is still within a normal range. The next thing listed after red blood cell is HGB. What do you think HGB stands for? Hemoglobin. And we asked you to memorize the normal hemoglobin level is about 15%, 15 grams of hemoglobin per 100 milliliters of blood. Hers is within the normal range. It's 13.1. Notice that females have a lower hemoglobin than males. They have a lower red blood cell count than males. They have a lower hemoglobin. What would it mean if her hemoglobin was lower than normal? Anemia. She's anemic. She's not, but if she had it lower than normal, she would be. Now, what's the next thing listed? HCT. What do you think HCT is? The hematocrit. The hematocrit, also known as the percent packed cell volume, is what proportion of your blood is blood cells. We asked you to memorize a normal hematocrit is 45%. All right? Her hematocrit is 40%. That's within the normal range.
Why is that
Okay, first of all, notice females have a lower hematocrit than males. If her hematocrit was lower than normal, she has too few red blood cells. The proportion of blood cells to her blood would be less than normal. Hers is normal, but if it was a lower hematocrit than normal, that would suggest the proportion of blood cells is less than it should be. So, in other words, there's many indicators here that would be indicative of anemia. Low red blood cell count, low hemoglobin, low hematocrit. And interestingly, because there are different types or causes of anemia, it's beyond the time we have to go into, but different types of anemia show up. Some show up as a low hematocrit, some show up as a low red blood cell count, some show up as a low hemoglobin. Because there are different types of anemia, different causes of anemia. Now, we're going to skip the next several things, which are, again, ways of evaluating anemia. Let's go to the next row labeled hematology. Now, they've listed the platelets. I did not ask you to memorize what a normal platelet count is, but hers is within the normal range. We have learned that a lower than normal platelet is called thrombocytopenia, and that means you're going to have trouble with blood clotting, because platelets play a key role in blood clotting. Now, what did they do next? They measured the polys, the lymphocytes, the monocytes, the eosinophils, and the basophils. This is called a differential white blood cell count. A differential white blood cell count. Let me explain what a differential white blood cell count is. Differential WBC count. I wrote that in. How did they do that? They take a sample of your blood, and a cytotechnologist stains your blood and identifies 100 white blood cells. And when they count these 100 white blood cells, they count how many of those 100 white blood cells were lymphocytes, how many of those 100 white blood cells were basophils, how many of those 100 white blood cells were eosinophils, so you have the idea? That's called a differential white blood cell count.
I did one many years ago with my
Right.
sister.
So what you do is the very first 100 white blood cells, you identify for each of those 100, what was it, a lymphocyte, an eosinophil? So obviously, if in this case, 38 of the 100 white blood cells were lymphocytes. So 38 out of 100 is 38%. Now, we asked you to memorize that a normal lymphocyte count's about 25%. 25% of all your white blood cells are lymphocytes. But this is still within the normal range. A little bit on the high side, but it's within the normal range. What would it mean if her lymphocyte count was lower than normal? It could be HIV. What would it mean if it was higher than a normal? Viral infection. Isn't that how we learn to interpret it? Now, monocytes are the macrophages. Eosinophils, eosin. What are eosinophils involved in? Allergic reactions. So if you see a higher than normal eosinophil count, that's an allergic reaction. The basophils, now we have very few basophils. The normal number of basophils is 1%. And even though they counted 0 out of any random 100 white blood cells, it's possible that you count 2 or you count 0 and it averages still to 1. So that's still considered normal. Basophils release histamine and heparin. Now the one I skipped, the first one was poly. What the hell are polys? Poly stands for polymorphonucleosides. Those are the neutrophils, the eosinophils, and the basophils. But we already know what the eosinophil count is. We know what the basophil count is. So what are all the other polys? If we know how many were basophils, we know how many were eosinophils, so the rest are neutrophils. Most polys are neutrophils. That's why I told you that neutrophils are also known as, we told you that term, polymorphonucleoside, or polys. So most neutrophils are polys. Then we learned that a normal neutrophil count is about 60%. 60 out of 100 white blood cells are neutrophils, the small phagocytes. Hers is within a normal range. All right, so now you know that when they look at these white blood cells, it's a way of evaluating the patient. Now, let's look at the lower down. Lower down on this page, we had already learned earlier, we had looked at this page, and this patient, they had measured her T4 level. T4 is another way of saying thyroxine. All right, and they measured it by radioimmunoassay. All right, and this was her T4 level, and this is the normal range. So we said she has hypothyroidism. They also measured her TSH level. TSH is another way of saying thyrotropin. And we learned that she's producing plenty of TSH. TSH, or thyrotropin, is released from the pituitary. So her pituitary is producing plenty of TSH. We explained, when we looked at this before, you might say, well, isn't that wrong? Isn't this a pathology? Look how high it is. It should be here. But we explained the reason why this is so high is because we know that what lowers the TSH is increasing thyroxine through a negative feedback loop. Since her thyrotropin, since her thyroxine or T4 level is so low, it's not inhibiting her pituitary. And so her pituitary is releasing lots and lots of TSH because there's not enough thyroxine to inhibit her pituitary. That's this negative feedback concept. If you know of anybody who has thyroid issues, you know that they are always looking at not only their T4 level, but their TSH level. And they want that TSH level to be, they want to give them enough thyroxine to inhibit their TSH level so that it falls within this normal range. So how they know how much thyroxine or synthroid to give a patient is to give them enough to lower the TSH, to inhibit it by negative feedback so it falls within the normal range. Let's summarize this patient. This is not an unusual patient. This patient has three major pathologies that we can see just from what we've looked at. We see that she has elevated, an elevated uric acid level. That's called gout. And she is going to be prescribed medication to control her uric acid levels, to lower them. The drug they would give, you don't have to know it, is called allopurinol. The most serious, well, let's look at another problem. Another problem she has is she has hypothyroidism. She's going to be taking Synthroid, probably for the rest of her life. She'll be taking medication for gout the rest of her life. And Synthroid, thyroid problems are really pretty common. There are many people who take Synthroid. It's one of the most prescribed medications, Synthroid, synthetic thyroxine.
Is there any preventive?
No, the reason why the person has to take it is because, for whatever reason, their own thyroid's not making enough. There are many causes of these disorders. There are autoimmune diseases where their immune system attacks their thyroid. That's what happens in Graves' disease or Hashimoto's disease. People could have cancer of their thyroid and they had to remove their thyroid gland. So then they have to take Synthroid for the rest of their life. If once they had a tumor or a cancer, they remove their thyroid. There are many things. The medicine is complicated. There's not a single thing that can cause, there are many things that can cause anemia. You can have iron deficiency anemia. You can have a vitamin B12 deficiency anemia. You can have a folic acid deficiency anemia. You can have damage to your bone marrow, and that's why it's anemic from chemotherapy. You can have sickle cell anemia. There are many types of anemia. So everything has multiple causes. If you've got elevated white blood cell count indicating you have an infection, what's the infection? There are thousands of different types of bacteria and viruses. So then you have to figure out which virus, which bacteria. Which bacteria will determine which antibiotic you're giving. So everything is multifactorial. Nothing is simple. Now, so there are patients on Synthroid. The most serious problem she has, though, is this problem here with her cholesterol. The high cholesterol and high LDL are dangerously high. This increases her risk of atherosclerosis, her increased risk of blood clots to her brain and her heart, and therefore increased risk of dying from a stroke or a heart attack. She's going to be given Lipitor or some other statin drug to lower her cholesterol level.